there have been 3 randomized clinical trials in the adjuvant radiation setting. And while all 3 have shown an improvement in biochemical survival, only one of them showed an improvement in overall survival. And on the control arm, on patients who just got observation, about 50% never developed PSA recurrence at 5 years. So it's really a lack of understanding who is the patient who is going to develop recurrence, who is the patient that will develop recurrence despite aggressive radiation therapy, and really who's the patient that will never develop, and can we figure out a way to differentiate these groups of patients. So our study was looking at a multi-institutional retrospective cohort. We had patients from Johns Hopkins University, the Duke VA, the Mayo Clinic, and Jefferson. And really what we were looking at is 3 different treatment paradigms. At Jefferson, we had used a combination of adjuvant radiation therapy and salvage radiation therapy. At the Duke and the Mayo Clinic, they had used exclusively salvage radiation therapy. And at Hopkins, they had a protocol where patients would not get any treatment until the development of metastatic disease. And we analyzed outcomes for these groups of patients, and we used 2 classifiers for that. One was a clinical classifier called CAPRA, which uses clinical pathologic features found on a pathology report after prostatectomy. In addition, we used the genomic signature decipher from a company, GenomeDx. And what we were able to show is that for the patients that for patients at low risk of recurrence, both by Decipher and by CAPRA, there really wasn't as much of a benefit as would be expected for adjuvant radiation therapy. But for those patients with more aggressive disease, and continuously as you increase whether the CAPRA score, the Decipher score, or both, we found that the difference in benefit actually was magnified. So for the patients that really had very aggressive disease, those were the patients that saw the greatest benefit of early initiation of radiation therapy. And so what this work allowed us to do was actually to create a threshold for a patient. So as a patient, you want to be able to ideally say, I'm willing to accept a 10% risk of X to avoid Y. And so what we're able to do based on this data is basically create a risk threshold for patients to use.